Hello, my name is Suhani Dalal, and I am a current first-year internal medicine resident at Loma Linda University. With the help of Dr. Esther Chong and Dr. Mojtaba Tari, I'm excited to be presenting our case, Bleeding in Compartment Syndrome After Pregnancy, Stat Hematology Consult. It is a case presentation about a patient with an acquired factor VIII inhibitor during pregnancy. I want to start off the presentation with a little bit of background about acquired hemophilia. Acquired hemophilia A, also known as AHA, is characterized by an inhibitor against coagulation factor VIII. It is a rare disorder caused by the development of IgG autoantibodies against endogenous factor VIII, leading to bleeding in patients. The most common bleeding in AHA is different from that of inherited hemophilia A, and is usually bleeding into skin or muscles, hematuria, melena, or prolonged postpartum or postoperative bleeding. Approximately 40 to 50% of cases are associated with other conditions, including the postpartum period, underlying malignancies, drugs, or autoimmune conditions. Our case is of a 33-year-old previously healthy female who gave birth to twins via cesarean section. The pregnancy was complicated by a postpartum hemorrhage due to a uterine hematoma. The extent of the uterine hematoma can be seen in the radiographic image in the middle, spanning 10 by 14 centimeters. In the subsequent months, the patient experienced easy bruising and swelling of her lower extremities. She has no personal or family history of bleeding disorders. She presented to an urgent care due to swelling of her right lower extremity. DVT ultrasound at the urgent care showed suspicion for DVT, and she was discharged with Eliquis 5 milligrams daily. She took one dose of the Eliquis, and after which she experienced increased swelling and pain of her right lower extremity, she went to the ED. The patient had a compression of a hematoma in the right lower extremity, resulting in compartment syndrome. In the MRI image shown in the middle, there is visualization of diffuse edema of the gastrocnemius and soleus muscles, contributing to the patient's compartment syndrome. Subsequently, she underwent fasciotomy of the right lower extremity and was noted to have an elevated PTT. Given the extent of her compartment syndrome, she was transferred to Loma Linda University Medical Center for further care. Initial workup showed elevated PTT during her hospitalization. A mixing study was ordered, which showed no correction of the PTT. Autoimmune workup was negative. Factor VIII level was decreased to 14%, and Beth-Zeta titer resulted positive for a factor VIII inhibitor. Thus was consistent with a diagnosis of AHA. She was treated with Novo-7, which is a recombinant factor VII, due to the suspicion for AHA. The patient was treated with rituximab to decrease immune response and thus decrease levels of factor VIII inhibitor. Rituximab was chosen due to minimal effects on wound healing when compared to other agents used for the treatment of a factor VIII inhibitor. After fasciotomy closure, prednisone was also started for further immunosuppression. So this case was particularly interesting because AHA is a very rare condition, affecting just 1 in 1 million per year. There's a strong association between pregnancy and the development of a factor VIII inhibitor. Cases typically arise about 1 to 4 months postpartum, but they can also present with symptoms during pregnancy as well. In cases of pregnancy-associated AHA, the inhibitor typically disappears after a mean period of about 30 months. The first goal of treatment is to prevent and control bleeding. First-line agents for this include recombinant activated factor VII, activated prothrombin complex, or recombinant porcine factor VIII. First-line treatments for inhibitor eradication are immunosuppressive agents, including corticosteroids alone, corticosteroids and cyclophosphamide, or corticosteroids and rituximab. Initial rituximab monotherapy is generally not recommended unless there is a contraindication to immunosuppressive therapies. Rituximab monotherapy was initially used in this patient due to an open fasciotomy with high risk of infection. So during my research, I came across a question regarding the future of treatment for patients with acquired hemophilia A. How can novel treatment modalities be used to help control bleeding in these patients and improve outcomes? So emicizumab is a bispecific humanized antibody used in the treatment of inherited hemophilia A. It works by binding to coagulation factors 9 and 10 and activating factor 10, which is the function of normal factor VIII. In 2017, emicizumab was FDA approved for the treatment of inherited hemophilia A in patients who were resistant to other treatment modalities. It would be interesting to see further research about the use of emicizumab in patients with acquired hemophilia A and if it has any benefit over other first-line treatments. It's really interesting and exciting to see where the future of research takes us in the management of acquired hemophilia A. And that concludes the case. Thank you for taking the time to listen to this presentation.